Our next presentation is another virtual rapid fire presentation from Dr. Nadine El Sayed, outcomes of carotid artery stenting in patients with carotid tandem lesions.
Good afternoon, everyone. My name is Nadine Sayed. I'm a research fellow at the University of California, San Diego. I'd like to start by thanking the Society and my mentor, Dr. Mulas, for the opportunity to present our work. We have nothing to disclose. Tandem lesion is defined as the simultaneous presence of high-grade stenosis or occlusion of the common and distal internal carotid artery. Management of tandem lesions of the common carotid artery and the ipsilateral internal carotid is challenging. It was found that in appropriately selected patients, concomitant carotid endarterectomy and ipsilateral carotid artery stenting can be safely performed in high-risk patients with a low risk of myocardial infarction, neurological events, and perioperative mortality when careful surgical technique is used. Using direct carotid access and distal carotid clamping for cerebral protection before stenting. On the other hand, the addition of endovascular treatment of tandem common carotid artery lesions with transfemoral carotid artery stenting was found to be associated with a threefold increase in perioperative stroke and death, utilizing data from the vascular study group of New England. However, data on outcomes of transcarotid artery revascularization for tandem lesions is scarce. We aim to describe the impact of tandem lesions on outcomes of TCAR and transfemoral CAS. We did a retrospective analysis of patients undergoing TCAR and transfemoral carotid artery stenting in the Vascular Quality Initiative database. Primary outcome was in-hospital stroke or death, and secondary outcomes included in-hospital stroke, death, stroke or TIA, and prolonged length of stay. Usual statistical methods were used, including multivariable logistic regression analysis, to assess the relationship between tandem lesions and in-hospital outcomes. Around 20,000 patients underwent TCAR, and 16,000 patients underwent transfemoral CAS. 4% of each had tandem lesions. There were no significant differences between tandem and non-tandem lesions in terms of demographics, medical comorbidities, and preoperative medications. However, patients with tandem lesions were more likely to be smokers and with ipsilateral stenosis more than 80%. When looking at patients undergoing TCAR, there was no difference in the risk of stroke or death, stroke or TIA, and prolonged length of stay on univariate or multivariate analysis. When looking at patients undergoing transfemoral stenting, tandem lesions were associated with higher risk of stroke or death, stroke or TIA, and prolonged length of stay on univariate analysis. On multivariate analysis, these differences persisted for stroke or TIA and prolonged length of stay. However, there was no longer a difference in the risk of stroke or death between tandem and non-tandem lesions. In conclusion, the presence of tandem lesions didn't seem to impact the risk of adverse events in patients undergoing TCAR. Tandem lesions were associated with 50% increased risk of stroke or TIA and 30% increased risk of prolonged length of stay in patients undergoing transfemoral CAS. Future studies comparing outcomes of TCAR versus transfemoral CAS in patients with tandem lesions are rented. Thank you for your attention.
This paper is open for discussion. And I guess I'll start, and I think that your data continues to probably amplify the differences between transfemoral and transcarotid stenting. And so I wonder, in your conclusion slide, you propose that further studies warranted to assess comparison between these two treatment groups. Do you really think that that's the case? And what I mean by that simply is, which cases or patients do you think are going to benefit from transfemoral approach to stenting with TCAR available? Are there certain selection criteria, and do you anticipate that there will be opportunity for this comparison?
Thank you for the question. I really think that we should compare TCAR versus transfemoral because this is one of the conditions which carotid endarterectomy cannot solve the problem here. So stenting may be the first approach of treatment. And as we all know that TCAR has contraindications, but transfemoral would always be with TCAR available. Transfemoral would always be as like would be offered as patients who are not eligible for TCAR. But understanding like more understanding of the impact of tandem lesions between these two procedures will definitely help choosing the perfect approach for these patients.
Thank you. Very nicely presented. And for the sake of time, I think we'll move on to the next talk.
Thank you.